Hi everyone, I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs Podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopaedic Society for Sports Medicine annual meeting in Nashville, Tennessee.
The AOSSM annual meeting is the premier sports medicine conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lecturers. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 7 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. Arthrex, a global leader in minimally invasive surgery, creating over 1,000 new products every year, thanks you for listening to this podcast. To learn more about how surgeons and Arthrex are treating the world's most elite athletes, please visit @ArthrexAthlete on Instagram.
Arthrex Athlete brings you the most inspiring stories of collegiate, professional, and Olympic athletes who have returned from their injuries thanks to their own determination, as well as talented surgeons, physical therapists, trainers, and advanced Arthrex innovations.
From college players to elite pros, Arthrex and their healthcare professionals are helping athletes recover and get back to doing what they love.
Again, that's @ArthrexAthlete on Instagram. Like, follow, and share these incredible comeback stories. You can also learn how to share your own by contacting patientstories@arthrex.com.
Hey everyone, before we dive in, we've got to give a quick shout out to AOSSM and their Sports Docs program. Such a great partnership and honestly something we've been really excited about since we began working together 3 years ago. Also, if you're in sports medicine, and if you're listening to this, you probably are, you've got to check out their virtual team physician series at sportsmed.org. It's packed with everything you need to keep athletes of all ages performing at their best, on the field or off. I've checked it out myself, and it's really a game changer. All right, let's get to today's guest. Today's episode is going to focus on the management of rotator cuff retears, including tips and tricks for successful revision repair and augmentation options. We are joined today by 2 outstanding guests.
Dr. Brian Waterman is a professor of orthopedic surgery at Wake Forest University School of Medicine, chief of sports medicine and shoulder surgery at Wake Forest Baptist Medical Center, and director of the Sports Medicine and Shoulder Surgery Fellowship. He is on the editorial board for Arthroscopy Journal and the American Journal of Orthopaedics. Dr. Waterman is a team physician for Wake Forest University, the Winston-Salem Dash, and U.S. Ski and Snowboard.
Dr. Gabriella Ode is an orthopedic surgeon specializing in sports medicine and shoulder surgery at the Hospital for Special Surgery, assistant professor of orthopedic surgery at Weill Cornell Medical College, and adjunct faculty with the Department of Bioengineering at Clemson University. She is also a team orthopedic surgeon for the New York Liberty of the WNBA. So without further ado, let's get to the exhibit hall.
Okay. All right, Brian, Gabby, thank you for joining us for this special episode of the Sports Docs Podcast in Nashville. We're super excited that you're here. I'm honored, and welcome to the show.
Thanks for having me.
Yeah.
Welcome.
Yeah, thanks for having me too.
Yeah. So today we're talking about how to address failed rotator cuff repair. And unfortunately, rotator cuff repair failure is still much higher than we would like, ranging from 13% up to 94%, which is quite high. So we know there are a lot of risk factors that contribute to why a repair fails, including patient characteristics, tear factors, surgical factors, all of that. So we want to start there. So Brian, when considering a patient for primary rotator cuff repair, what are some factors you look for to determine their risk of potential failure?
Yeah, ultimately I think you need to look at a couple different factors. So the demographic things, the things that the patient brings with them, age, sex, bone mineral density. Then there's tear characteristics, size, pattern, tendon of involvement. And then there are physical exam findings, lag signs, active and passive range of motion, any other extenuating circumstances, biceps pathology, AC joint pathology. Those are all the things that I want to ensure to make sure we generate both functional success as well as improve patient-reported outcome measures.
Mm-hmm. Absolutely.
Yeah, Gabby, anything to add that you're looking at?
Yeah, some of the characteristics you mentioned are really important. Also on the MRI, the tendon quality, and going into detail about that. The age of the tear, how the tear occurred. So a traumatic tear where there's a fresh rip is usually going to have a better outcome than what we call as a non-traumatic tear where it's been slowly wearing out over time. And so that's a process that kind of speaks to the quality and the health and biology of the tendon. And then there are some what we call modifiable risk factors that with patients you want to optimize as much as possible. Are they a smoker?
Yeah.
You know, are they a diabetic? And if they are, is it well controlled? Is it poorly controlled? You know, those are two things that can certainly, improving those factors can, you know, we know that they can significantly improve the likelihood of healing.
Now, about smoking, do you make patients quit smoking before you'll do a cuff repair? Do you test them to ensure that they've quit smoking? How do you tackle that?
I do make patients quit.
Yeah. Good.
I do make patients quit. You know, I think there's some gray area there. You know, if somebody has been smoking 3 packs a day for 20 years, that's a hard conversation to have. You know, so, you know, there are patients who, hey, I'm working to quit. I think I don't just say, hey, quit and come back. I want to make sure that they have some sort of guidance. You can test them, you know, immediately afterwards. If it's a high-risk tear, I will test them. If it's, you know, a relatively smaller one, we'll check back in, get a sense of, you know, what their nicotine intake is. If, you know, obviously I'd want them to have several weeks, you know, with no nicotine in their system, but that sometimes time's also not on your side.
Yeah.
And so there's a little bit of wiggle room there. But in a perfect world, yes, I would tell a patient, no, you have to quit smoking because we just know that the tendons don't heal if you smoke.
Yeah.
And I tell them, you know, it's a waste of your time and my time,
Yeah.
truthfully, to go through a huge repair like that and then you're smoking and it doesn't heal.
Yeah. Why
Yeah.
do it?
True. Brian, you're south of the Mason-Dixon,
Yes.
right? So
Tobacco
I was
Road.
waiting for the elephant in the room.
Okay, so we, my brief, quick story. I did graduate school. Before I went to medical school, I was in graduate school in Richmond, and my job was a cigar girl. So I had the, at a restaurant, like the box with the cigars and the cigarettes and great living.
Were
But
you alive in the 20s?
Yeah.
This sounds like a somewhat of a dated profession.
but anyway, it's a great job. Got me through graduate school, but I couldn't believe the amount of people that smoked. You know, what's your experience?
Yeah, I mean, it is, as Gabby alluded to, sometimes that's a little bit more of a delicate thing depending on the population that you're situated with. I have a lot of the same discussion points. Maybe that's not as much of a limiting factor for a primary, but definitely for a revision or any case where I'm using some additional technology such as augmentation. I think that needs to be part of the discussion. I briefly review kind of some of the mechanistic effects. I tell them that it's not because I'm a teetotaler or, you know, I really want to constrain their lifestyle, but it is important that it does limit vascularity, healing, and puts them at heightened risk for adverse events. My dictation software picks that up. It's in the note, and I tell them ideally the data suggests that you should be tobacco-free or at least minimized at least 6 weeks prior to surgery. In a revision setting, I'll make sure that they have contracted with me verbally. I don't test.
Yeah. Honestly, I find that when I test, so I'll make people quit. I test the codeine test. It's out of their system. And then they just start smoking again like a week after surgery. So it's almost like, you know, if they're going to do it, they're going to do it. Like I can put them through the test, but it's one of those things. I think all you can do is counsel and try to get them to do the right thing. But you're not going home with them, so you're not, you know.
The other thing that comes up obviously is vaping and some of the nicotine replacement stuff. So you know, you got to make sure you broaden that discussion, not just traditional smoking, which is very endemic in my population, but also in the younger generation, a lot of the other alternative forms.
Vaping,
Yeah.
It's a big issue.
Yeah, for sure. So let's move on to you know, the workup. So Gabby, let's talk a little bit about your history and your exam, your imaging. So you know, share with the listeners how you get started.
Say if I have a patient who's coming to see me for shoulder pain and description, you know, starting to tease out, is this a rotator cuff issue or is this arthritis or something else that's around the shoulder? I do routinely get x-rays. Sometimes patients will push back and be like, hey, I came with an MRI. Why do I need an x-ray? And then I tell them it's because I want to see what's been going on for a while. You know, is this something that, you know, your x-rays look totally normal, or are we showing signs that your rotator cuff has not been working for a longer period of time? Because that will, you know, educate what our options are. If it looks like there's been a chronic tear or they're getting arthritis related to the rotator cuff, that's a totally different conversation then. When I see somebody and, if they're coming in for the first time and they have physical exam findings that tell me, hey, their rotator cuff is bothering them. If they're not weak, then you can have a conversation and say, hey, let's start with the things that we know work, like physical therapy, over-the-counter anti-inflammatories. Let's make sure the muscles are conditioned as best as possible. If there's weakness, then I will get an MRI. I'll jump right to that first just to get a sense of, okay, what's our path here? And that won't necessarily mean that we're jumping right to surgery if there's a rotator cuff tear. That means a lot of different things. But it just means that we need to have a discussion of what are the next steps, how long are we going to try non-operative management, what does surgery offer that might benefit or be not kind of right fit for you right now. So it just enriches the conversation.
Definitely. So now let's talk about the treatment. Specifically, we'll focus on the surgical treatment. So Brian, you both work with residents and fellows, but Brian, we'll start with you. What are some tips and tricks that you give your fellows, some wisdom you bestow upon them in terms of managing these revision rotator cuffs, in terms of like fluid management and arthroscopic visualization? Like, what are some tips and tricks to optimize this surgery?
Yeah, I think the workup, or at least the thought process, starts before you get into the operating room. So knowing all those key variables, what was done at the time of a primary, trying to get a root cause analysis of the source of failure, and then really thinking about also the zebras, right? Infection, some sort of foreign body reaction, loose implant, these sorts of things. So any of the prior imaging, documentation, and then it's the time of surgery. So to getting a good preoperative assessment of their range of motion, any scapular compensation. You're making sure that you're ruling out anything upstream in the cervical spine. At the time of surgery, then, it's really about trying to get an appreciation for any unrecognized delamination, inappropriate reduction. I've been misled by trying to identify that tear pattern and getting that right back to the anatomic tension-free configuration of that tear. And then really looking for other potential areas or pitfalls, the missed subscapularis tear, bicipital pathology, making sure you're doing appropriate releases. So I really thoroughly excavate that rotator interval tissue. I think another key thing is to make sure you're evaluating those tissue planes and the reduction from the lateral aspect. And then really you want to make sure you have a decision for augmentation early on, because you'll always try to talk yourself out of it as your procedure goes along.
Yes.
That's
actually a good point.
Yeah, just what we wanted to sort of start to dive into. So Gabby, you already talked about integrity of the tissue and, is this a slow moving process that's going to speak to, the quality of the tissue. So, as far as augmentation, how does that play in, as Brian said, are you always planning for it? Is that always a standard part? Speak to that.
It depends what the MRI shows me, how old the tear is, if it's non-traumatic, and their age too.
Yeah.
So if I have a patient that's 70 and meets the indication to have a repair, I'm pretty routinely putting some form of biology on top of that repair, usually a collagen patch of different ones. If there's a question of kind of a structural problem, like there's not enough excursion or elasticity of the tendon, and I need something to help augment my repair with structure, then I'll either do a collagen patch that has kind of a structural integrity associated with it, or there are different dermal patches that you can use, like cuff mend, or different ones where it's just kind of specific dermal tissue. Things that can help, provide a little bit of additional coverage on top of the tendon. And then, there are other factors at play. Do I want to protect my repair? And so there's some other options that you can use to, protect the repair in addition to the patch, or add a balloon spacer. That's off-label, but that's one way, have some good indications or good results with, having a higher risk repair, and you want to kind of make sure that the humeral head is not migrating while this tendon is healing. So if I have somebody that is a revision, I'm probably augmenting them with something based on all of those factors. And that will depend on the level of tissue quality, the the age of the patient, what was done before, and then also how much space you have too. You know, so I mean, if they've had a previous double row repair, they have a lot of anchors in there. Then I think there's nothing wrong with doing what's called a margin convergence, which is just bringing the tissue across, maybe a single row repair if there's space, minimizing tension on the repair, and then augmenting if it's available, because I want a low tension repair that reconstructs the issues that contribute to the failure before.
Sure. Yeah. So, Gabby, you just mentioned the dermal allograft and the cuff mend, but there are also autograft options that are available as well, like the long-headed biceps tendon.
Yeah.
And so Arthrex has that autograft tissue compression system. It's also bicep smash, it's called. So, Brian, what are some of the benefits of using a biceps autograft in terms of like healing rates? And is this something that you're routinely doing or think that you'll do in the future?
Yeah, you know, a lot of it is determined by the OR setting. So in my ASC, where I'm a little bit more accountable for my costs, you know, I always say we buy local, right? You have 2.7 centimeters that you can get from the biceps. You usually will cut it, truncate it, smash it, and then you can apply that. And that has great tenocyte proliferation, great integration. It is structural. And I think it's something that accomplishes a very similar endpoint as you get with cuff mend. In terms of the instrumentation, it's also very similar. I tell you, increasingly, though, I'm looking at ways that you can integrate in the biceps into your construct, whether that's an anterior cable reconstruction, a centralization or rerouting procedure, or these various permutations of a bio-SCR. So that's been the biggest paradigm shift in my practice in probably the last 2 years, is thinking about leaving that intact on the superior labrum and then trying to use that as a strut rather than addressing it as a pain generator reflexively.
Yeah, I think that's interesting.
Yeah.
You know, in addition to these scaffold options, we also talk about orthobiologics. So, you know, we're hopeful that it'll improve our rotator cuff healing. You know, you're seeing a lot of variability in our data that, you know, I think we all know it's a hard problem to study. You know, just given the variability of like, you know, quote unquote PRP, is it the same at your place as your place? No, you know, so a lot of variability. There's also like cellular options, including bone marrow concentrate. So, Gabby, as far as the others, you know, how do they play into your practice?
Yeah, they don't really have a significant role in my practice right now. You know, I agree about buying local, but
I like
you know,
that.
Maybe not that local.
Yeah.
So even at the time, you know, I will, you know, freshen up the footprint. If there's a CA ligament lesion, I'll do a subacromial decompression. And I do think that those bone marrow elements can help, and it's right there.
Yeah.
I'm not entirely sure exactly what is the cell count, what are the factors, healing factors with PRP and BMAC that we know can consistently provide improved healing beyond what you can provide with just kind of the, you know, the blood and factors that are there, or the marrow venting with your lateral row anchors, which is another, you know, way that you can kind of improve some biological factors there. So I think it remains this black box where we really don't know what works and in what situation, you know, who has good bone marrow, right? And particularly in the proximal humerus. I think other things that we can consider is vitamin D level, right? You know, how do you biologically optimize a patient? You know, are there certain supplements that may help with healing potential before and afterwards? That may provide a better opportunity for them to heal their tendon, as opposed to just the, you know, local options at the time.
Yeah, I think we still have a lot to learn in this area. We had Scott Rodeo on. Was that last year or the year before? Was that our first
2 years ago.
2 years ago? And he's talking about the biggest problem is, well, one, yes, defining. You know, what we all want to call it stem cell injections, and they're not, right? But then also, like, how do you get it to stay there? You're just going to, like, inject it and it just floats away. So how do you deliver it? How do you make sure it stays there? How do you study this? So, like, I feel like we fast forward 15 years, maybe we'll have a grasp on this, but I just feel like right now there's still so much we don't know.
Well, and you also, I think, importantly brought up the nutrition, and that's been introduced more and more, I think, in a lot of our practices of, you know, Pat Denard talks about it all the time, you know, with like, he used to, he said by hand, he was telling us on the show that like he would basically give a prescription of like, I would like you to go to the supermarket and get this supplement. And, you talk a lot about vitamin D and try and sort of be respectful of all these other things that impact healing. So Brian, have you, delved into that at all? As like, we're not nutritionists, but do you start to talk about nutrition and the importance there? Or do you test vitamin D?
Not routinely. I mean, I think that gets to the Rohe score, which you haven't brought up.
Yeah.
But I do think that there are proxies for bone density that you can lean on, whether that's disuse osteopenia on the radiographs or just the bone handling when you're doing a light preparation.
Mm-hmm.
To your point about looking at some dietary screening questions, I think that's effective. I don't know if we know which questions to ask. But I do think we can take a proactive stance, whether that's doing a preparatory package before surgery to make sure they're optimized, to giving them customized packages on the back end where they can utilize that for the first 3 weeks, where I think it's much more critical. I would say that that's been another paradigm shift, is really trying to be more proactive about protein intake.
Sure.
And so we are looking at that. I have those aspects featured on our site. One of the big limitations is really the economics of it all.
Yeah.
Where do you allocate your resources, whether it's a biologic adjunct, which is a cash pay at the time of surgery, versus a post-operative package, versus some of the supplements. Buddy Savoie has a list of supplements that are cost-effective that I advocate for all of our patients. But let's be honest, probably the broader majority of them don't. The other thing that people routinely ask now, especially in the high-performance patient population, is peptides.
Yeah, we were just going to...
BPC 157.
I know you were going to say that. We had
did
to do
a whole
a special episode on
this.
it.
Because if one more patient asked me about this, they were like, BPC, that's like, it sounds like a submarine. I was like, what is this? I'm like Googling. We did a whole study on it. It's so interesting how it was discovered in gastric juice, like in stomach juice studies. It's crazy. But
can I submit for a different, maybe origin? Gastric juice just doesn't pop off the page for me.
It really doesn't.
Maybe it'll steer some people away from it.
Primordial soup.
Gastric juice.
I think you do bring up a point, though, that, patients can get in the weeds in the biology side of things. And the rotator cuff is so nuanced because so much of it is mechanics. Yeah. And this is a philosophical debate I have with a patient of mine right now that needs a revision cuff repair. And I've told her, like, we kind of need to get on this. We're losing steam on the ability and elasticity of that tendon. She was like, I need 3 months to get my peptides and my biological,
Brooklyn, baby.
Wow. Is that what it is?
And so with that, I was like, I understand what you're saying. I hear what you're saying, but there's biology and then there's also physics.
Yeah.
And, the physics are telling us that time tells us there's a limit here on this. And in order to get a good recovery and as much healing as possible, this is something that needs to be done sooner rather than later.
Yeah.
And I do think that's different than some other, fields where we focus on tendon healing, where, around the elbow or patellar tendon is, the force couple of the rotator cuff is critically important. You're trying to preserve the rest of the tendons. You're trying to preserve how the rotator cuff moves. Why are some patients have huge tears and are able to lift their arm all the way up overhead, and the other ones have tiny tears and they're just struggling, and it's because of the mechanics around the rotator cuff and the dynamic processes around the rotator cuff, which are very different. And that's where the biology is alone, I think, is just not enough to, address the issues and improve their outcomes after.
Yeah. We're proud to partner with the Unbroken Athlete. Every game, every practice, every moment matters when you're chasing greatness. But peak performance doesn't just happen. It's built.
The Unbroken Athlete helps build it. With expert tools to sharpen your mindset, fuel your body with smart nutrition, and recover from injury like a pro. Because true athletes know what you do off the field is just as important as what you do on it.
And now, whether it's for preventative, performance, or rehab, you can help others build their best too. Join the Unbroken Athlete Affiliate Program and share our programs with your friends, family, and team at a discount while earning a commission when they join. It's a win-win for you and your community.
And don't forget to sign up for the Unbroken Athlete newsletter, packed with the latest research and actionable tips on nutrition, fueling, recovery, mindset, and resilience, delivered right to your inbox.
Visit theunbrokenathlete.com today to join the affiliate program, subscribe to the newsletter, and don't forget to follow along on Instagram at theunbroken_athlete for even more. So now let's shift our discussion to treatment of irreparable rotator cuff tears. So hopefully your patient doesn't optimize her peptides too long and makes it to the OR.
Yeah, we have a different conversation in a few months.
Exactly. So the options we want to discuss, we have superior capsular reconstruction, SCR, interpositional options like you mentioned, the balloon, biologic tuberoplasty, tendon transfers, and of course reverse arthroplasty. So we want to start with SCR. So Brian, you've published a fair amount on SCR. You also just mentioned SCR combined with anterior cable reconstruction. Can you talk a little bit about your indications to do that, and then also your technique?
Yeah, I think when in the traditional sense of the SCR, that probably has a more limited footprint for that within my current practice, but here are the people that I think could benefit for it. One is you can get the tendon back to the footprint, but under a little bit of tension. That may be an individual I would consider an SCR with a cuff repair over the top of it. They have to have well-preserved range of motion. They have to have decent tissue quality. Typically, that's in a patient that's younger than 60, and they have lower occupational or physical demands. And so, taken in sum, that's a smaller patient selection. Vis-a-vis biologic tuberoplasty is probably somebody that is going to hug the turns on life a little bit more, maybe have a higher activity profile. I'm going to let them go sooner, and we're just trying to do that as a pain mitigating procedure. So less precautions there.
Hug the turns on life.
Yes, I like that.
Yeah, that's great. Gabby, similarly, is SCR much of your practice these days?
It is not. I on the bio-SCR, using the biceps, yes.
Yeah.
So if I have a healthy biceps tendon and a massive, supra-infra tear, or if the anterior cable is disrupted, I'll do exactly what Brian was mentioning. I'll keep the biceps, I'll route it there, and then I'll repair the rotator cuff on top of the biceps, and then if I can get it all the way to the footprint, I'll repair it that way. So using that as a primary option first is the closest thing to an SCR. So really when you're talking about is what's above and below these repairs, right? So other options like the balloon is something that you can add if it's irreparable. You can do margin convergence without a balloon. Tendon transfers are certainly, increasing our arsenal of ways to manage irreparable cuff tears, particularly if somebody has an external rotation lag or weakness, or they're a younger patient who's higher demand and not at a level they're ready for a reverse shoulder replacement.
Yeah, absolutely. So we would like to talk about that a little bit more, the tendon transfers. So in terms of tendon transfers, there's the lower trap transfer, right? The lat dorsa transfer. Which one do you prefer and why?
I'm new to this game, but the lower trap transfer, and I think in the appropriately selected patient is very powerful. I think you get fewer and fewer of these patients that fall into that category, which is that they have primary external rotation weakness, failed cuff, young. But in those patients, I think the lower trap transfer is quite powerful, particularly in a revision setting, because you're addressing an issue that has significant functional deficit by rerouting, the lower trap in line with the infraspinatus, and then providing some coverage with the cadaver, usually Achilles tendon. On top of that, I have not done a latissimus dorsi transfer, so it's not something that's in my skill set to kind of comment on. But the tendon transfers in general provide a good option, particularly for those higher demand patients, those younger patients, or the ones where they need more power. So from a strength standpoint. Unless the patients who their primary complaint is, say, pain. For me, if a patient or their primary complaint is pain, if their function is okay, then we're going to talk about palliative procedures like biceps tenotomy, biceps tenodesis, which does work and has good outcomes in massive irreparable cuff tears in patients who still have good overhead function. Balloon if they're again limited category, but still potentially helpful for pain, and then a reverse shoulder replacement works great for both pain and function.
That's right.
But not always something that I would jump right to.
Yeah, Brian, as far as, and you also have a lot of military experience, obviously.
Yeah.
How do you, is a tendon transfer, is that something that you're doing with your military population? How did that fall into your practice?
Yeah, that was something that probably came afterwards. I don't think there was a widespread adoption curve until the lower trap really emerged on the scene and was popularized. And I think the individual that I'm looking for is the one that has full passive and active range of motion, forward flexion, abduction. They cannot be pseudoparetic. They generally are in that younger, more active stage, so probably less than 60 in general. And then really I'm looking for those lag signs. Those are the individuals that are going to respond most appropriately for that. So if they have ER lag, and people will try to parse that out, where's the ER lag? Is it at 90 degrees of abduction or at their side? To be honest, I don't think lat is in my algorithm for posterior superior irreparable cuff with infraspinatus. I think a in-phase pull of a lower trap and just the robust tissue quality is a little bit more reproducible in my hands. So it doesn't matter for me as much whether it's ER1 or ER2. You do have to make sure that individual is bought in on a little bit more of a slow-paced rehab protocol, and that they're going to be compliant with, immobilization and external rotation to try to get maximal pull. But I've seen some good success with it. I think that is more reproducible. And let's be honest, I think there is probably a little bit of a biologic spacer effect, too, if you have an irreparable supra. So I'll try to do as much as I can to advance the existing supraspinatus stump to that, maybe do a bicep centralization. So kind of taking an all-hands-on-deck kind of approach in order to achieve humeral head depression, because that's, I think, one of the biggest predictors of attrition, which is osteoarthritic progression, which we don't know the rate of that.
Yeah, fair.
So speaking of osteoarthritic progression, we do want to wrap up with reverse shoulder arthroplasty. And Gabby,
yes,
you've published a fair amount on this topic, so we do want to get your take. I think historically we're always taught, older rotator cuff arthropathy, just improve function. But I think people are doing reverses in younger and younger people. Yeah. What are your indications to do a reverse? How do you decide on that versus one of the other procedures you were talking about?
If a patient has a massive irreparable cuff tear and they have pseudoparalysis, we're going straight to reverse. I just don't think that is something that is restorable with the other procedures, because the mechanics are altered so significantly that it's a long run for a short slide.
Yeah.
And that's the conversation to have with patients. The patient where they're like, hey, I have pain, but they're getting to like 160 of forward elevation. They've got relatively preserved strength. We're hitting pause, and we're going to have a conversation as to what to expect after reverse. Because I think the challenge is we know the reverse is a very reliable procedure, very reliably addresses pain, and very reliably can get somebody overhead to like a high cabinet level. It's unpredictable with rotation. We know that, external rotation and certainly internal rotation. So the conversation with the patient is, what are your goals? Are you trying to get back to kind of daily activities? Are you trying to just kind of be able to, hey, I just want to reach my high cabinet and get things down? What are their goals in terms of activity? And if they're like, hey, I want good pain control. I want a consistent ability to lift overhead. I don't want to be in a sling for 6 weeks. And I don't want a long rehab period. And I'm a little bit on the older side, then I think that's a great indication for a reverse. The gray area, the younger patients, the patients who have, are well compensated, meaning that they can get overhead, but maybe they want a little bit more, probably very unpredictable. You're going to gain more on a reverse. Maybe you will. Maybe your function is fantastic, but not as predictable in that setting. And we also know that once you kind of cross that path, there's no going back.
Nope.
So that's where, it's true. All those other things for massive irreparable cuff tears, we shouldn't, disregard, which is release the biceps, do a partial repair, in somebody who has good function, maybe limitations in terms of pain. I don't think that we have to jump right to, the big whack every time if they're not quite there, both function and, kind of preparation-wise. That being said, I love reverse.
Yeah.
I love doing reverse shoulder replacements. Those patients are my happiest patients, and the recovery for many of them is a lot easier than like a big revision, tendon transfer, even all of those things are a huge commitment, and it's a lot of time.
And less reliability.
So I think once patients understand, hey, what's your risk? What's your risk tolerance? Then you can get a better you can get a better sense of what's the right procedure for them.
So Brian, when I trained in Vail, we would have, Dr. Millett would have these patients who he'd indicate appropriately, but they're young and they want to rock climb and they want to fly fish and they want to do all the things. So if you've indicated someone who is on the younger side, but appropriate indication, how worried are you as far as like letting them return to things, and how do you counsel?
Yeah, and this is specific to rotator cuff or
reverse?
reverse?
I'm sorry, for the reverse.
Okay, the reverse.
Yeah.
So, I think much of that discussion of the failed rotator cuff or the complex primary rotator cuff that probably is not going to be repairable is expectation management. And Gabby was alluding to that perfectly. I worry about the individual that has full range of motion, that's talking about this activity profile, or they're just, quote unquote, not bad enough, whether that's by your SANE or ASES score. I often talk mostly about ADLs when it comes to limitations in range of motion, and that's internal rotation. These are individuals that also I think about longevity. So think about whether there is the presence of some sort of deltoid fatigue phenomenon that does occur over time. Those individuals, I really probably look more preferentially at what we would call an anatomic reverse, so building out a little bit more lateralization. I also look at repairing the subscapularis. I know the discussion points on that, but I still pursue that. And then really, to the extent that they're involved in a specific type of activity, I don't have the rock climbing stats, but a lot of people talk about, racket sports. They talk about golf, and
pickleball.
Pickleball. I can pull those down off the shelf. Even firearms. I generally have that on command. But
not a question I have to answer in New Jersey, but I guess
that is a Colorado one. Yeah, I've literally gotten requests for, can you type a note? Can your office type a note to tell my wife that I'm allowed to go to the range? Because hunting season is coming up.
Yeah,
go ahead. Sorry.
But no. I think it's fascinating because I really am trying to see where can we tweak things in order to make sure people have optimized function. Yeah. At the end of the day, it's a non-anatomic solution for an irreparable cuff problem, and so we're really just trying to make sure we try to restore it as much as possible. I think that's where the templating software, and Gabby's been very heavily involved in a lot of this, is helpful. To try to simulate range of motion, make sure we're removing any osseous conflict that may be impending, and then just trying to restore the muscle tendon units to the point where they can achieve maximal range of motion.
Yeah. The last thing I want to wrap up with is recovery, rehab and recovery after. And let's go back to revision rotator cuff, because I'm curious to hear your thoughts on this. Because, the sling immobilization, how long, when to start PT after primary, I feel like it's kind of like, it's surgeon dependent. But with a revision, how do you change your recovery? Do you keep it in a sling longer? Do you delay the onset of PT? What do you do to protect that repair?
I think you just have to have clear guidelines. For me, the longest I'm keeping somebody in a sling is 6 weeks. And that's with a primary repair that's big, so a large cuff tear, or in a revision setting. But I do have very clear guidelines with patients when they come out of their sling. And I think that's just a quality of life thing that also helps. So for me, if a patient is, seated in a chair and they can put their arm in a neutral position, I tell them explicitly, come out of your sling. Because so much of the pain profile is because they're hiking their shoulder up, their traps hurt, and they're like, I'm in this for 6 weeks, this is miserable. And then also, if their hand is on their belly, they're also contracted, and then they're more likely to also have some, anterior capsular contraction that you're having to work through afterwards. So as long as they can keep their arm kind of comfortable, then I'm pretty liberal about the sling in that setting. But if they're up and walking around, they're in the sling. And they're sleeping in the sling. If they leave the house, they're in the sling. And so, if I'm not doing anything to their biceps, I tell them come out of the, stretch your elbow out. PT for me, I start them early, but they're not doing much early. I just want to make sure that they're building a good relationship with their therapist They're going a couple times to know what are safe movements to do in that first month or so. They're getting some pain relieving, modalities as well. And I tell them the work starts at, 6 weeks, around that time period where you're going to be doing a little bit more at that time. And I think that early counseling is helpful to patients, so they're not like, hey, I'm incapacitated for 6 weeks.
Right.
And I tell them, I'm like, hold a coffee cup in that hand. Like just do something where you can feel a little bit more normal.
Go take a walk.
Go take a walk,
Yes.
So I think it helps.
Yeah. Any additions to your rehab?
Yeah, no, I think it starts with an early discussion with your therapist. Obviously, you've been in the shoulder. You can communicate the risk profile. And so we have several different algorithms. We go with a conservative profile. I say this is a massive, irreparable one with subscap precautions. So let's proceed cautiously. And then there's, it's kind of like the angel on one side, the devil on the other. I have these two voices in my head. I just want to immobilize them. I want to get good scapular mechanics. But at the same point in time, I have our therapist constantly chirping in my ear about, active, assisted, pendulum-supported exercises are completely safe. And you do want to get some muscle activation that may have some ability to potentiate healing process. But I try to individualize it.
Me too.
And I don't know if the right answer. I'd be interested in hearing what you ladies think.
No, I agree with a lot what was said. Like, I really want people, I do get in PT early, even though there's not that much to do in the first 6 weeks. I think a couple things. You get the safe movements. You get, you're starting to avoid that upper trap, sort of like scapular hiking that they all love to do. It also, I think, mentally, just sort of helps to get them, okay, I'm out of the house, I'm starting to do things. I think there's plenty of stuff that they can do that has nothing to do with their shoulder. So that's something we encourage a lot, is like, I would love for you to go to the gym. I'd love for you to get on the stationary bike, like, all those sort of things. I like that.
For me, I think it depends on how many visits of PT they get too.
Sure.
Because I think, especially with the revision, they're going to be in PT for so much longer. So if they have a great number, then absolutely. I agree with everything you guys just said. Get them in, get them doing cervical spine, conditioning, safe movements, like you said, building a relationship. If they're limited, I actually delay the start of PT to 4 weeks with a revision, just because I feel like they're not doing very much up until that point. And then, like, recently, especially for revisions, I'm a big fan of the BFR, the proximal BFR. I just feel like it releases growth factors, and it can help with some of that muscle that's been re-traumatized, and people are doing pretty well with that. So I think
we had Eddie Chang on, and he was talking about that, like their work that they're doing, which is contralateral BFR. And it's interesting. So I think,
cool.
I think therapy also has the potential to establish the guardrails on your relationship. And, the do's and don'ts. I always say we want to feed the beast. I want to give you something that you can do so you don't get tempted into the forbidden zone.
Absolutely. Yeah, you got to give a little, because, it really is. It's torture, to just think you're totally locked up. And if you're, sort of putting them in a bubble, it's,
got to give something.
Yeah, absolutely.
Awesome. Well, thank you guys so much for taking the time to join us here today. This was fantastic.
You guys are awesome.
Yeah, you guys are great. So
we're super honored to have you on. You guys are obviously very well published. You're always on the podium, big leaders in this space. So thank you for sharing your time.
Thank you.
Thank you.
Awesome. Thank you.
Awesome. Thank you.
Thanks, everyone.
All right, thank you.
Thank you for listening to this episode of the Sports Talks podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportstalkpod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback.